Mark, you want to come up as well, and Paul as well, and I think we have some time for questions, so we'd really welcome that from you. Guys, we have microphones here from you. Thank you. Oh, go ahead, Mark.
I just wanted to make one real quick comment, something I didn't mention. If you're doing a less invasive operation, robotic or minimally invasive, you may feel like you want to put a smaller chest tube in the person because that's consistent with your minimally invasive option. So I feel very comfortable putting the 24 French instead of a 32 or 36 French tube for a smaller incision patient, put a small tube, less pain, and ensure drainage.
You had a question, sir?
Average patients, do you recommend putting a separate chest tube on the throat side in addition to the external chest tube? That's the first question. And the second question is, I have a hard time reading this data until the randomized study comes out because most of the patients that we have clotting problems, it's a biochemical process. You give them platelets and first Pleural Tube, they clot not only in the chest tube, but also inside the cardiothoracic sac. Clearing the physical obstruction of the chest tube is not going to take care of the clots that actually form. So it's not going to prevent that subset of populations that have already bled and clotted up. It's going to probably help that smaller population that is still ongoing bleeding. I don't know why not just chest resuction is going to take care of it. So the biggest problem we have is this diffuse clotting that happens when you take patients back. You don't see free clotting. I mean, free clotting is the cardiac sac. You see clots.
I might take to be. Yeah.
This randomized study, did it allow the surgeons to frequently suction their standard chest tubes? Because my protocol, my understanding of the protocol is that you actually suction the chest tube every 15 minutes for 3 hours. Does the randomization allow frequent suction of the standard chest tubes?
Well, of course not. And I want to make a precision. I mean, we're actuating the device, so the plunger, if you like, is actually done at a regular interval, and it's just a suggestion. I can tell you, in my unit, the nurse says, "I don't need you to tell me when I need to do it. If it's bleeding, I'll do it more, and if it's not bleeding, don't bother me." So, and obviously on the standard group, it is standard suction. It's continuous suction, so that doesn't change. And obviously we cared about the patient first. If we think they're clogging, then we might resort to the ancestral techniques of stripping, milking, and all that good stuff. So, and on your objection, you have to remember, the chest tube will not prevent bleeding. It will just make sure it will lessen the chance of having too great of an accumulation. If the bleeding is brisk, perhaps the chest tube is not going to be able to take everything, but having this mechanism to optimize the patency will likely decrease this accumulation.
Let me also clear up one misconception. This is not a device which is designed to reactively unblock chest tubes. The mechanism of action is preventative, and it avoids chest tube occlusion and allows proper drainage in the first place. And by allowing proper drainage, the absence of large amounts of blood actually is very beneficial to hemostasis in the first instance. So everybody knows and agrees that bleeding begets bleeding. By achieving proper evacuation of shed blood, the propagation of normal hemostasis is restored earlier. And that's really one of the primary benefits. Of course, we don't remove all the blood and all the clot. There's a residual amount inherent in surgery that is unavoidably going to be left behind. But if you regard retained blood as fuel, as an inflammatory agent, then it's a question of degrees. And clearly, the association between the amount of fuel available to mediate an inflammatory process is very important. And by having optimal evacuation of shed blood, the available fuel to drive this inflammatory process, which is well demonstrated. The markers from pericardial blood are profoundly elevated compared to the same patient, same time arterial sample. When that blood is removed, this inflammatory process is dampened, and that results in the lower incidence of observed post-op atrial fibrillation. So I want to be clear, this isn't a reactive device to get a clot out. This is a morcellating device that prevents clots from forming in the first place. So just to be clear about that.
I think another concept that is important to consider is, I think you're right. When a patient comes out from the operating room to the ICU, they're still coagulopathic in many cases, and so the blood is not clotting. Then the nurses warm up the patient, they give the coag factors, the platelets, and there's this, what we've called phase change, where it's kind of going from the liquid blood to the clotty blood. And that's the most critical moment to keep that chest tube open. Because if you keep that chest tube open during that change, which happens, who knows, 4 hours out or 6 hours or 3 hours, keep it open during that phase and get as much of that blood out during that. I think if you fail to do that and there is clot that builds up in that tube and you get blood left behind, yeah, you're right. When you go back, you're not going to find free blood. You're going to find a big giant clot. Now, we did this in the lab, in the porcine model, and we also have a kind of a benchtop model. And if it's like if you put a chest tube into a bag, it just sucks that whole space down. And if you keep that space sucked down, it prevents that accumulation of fluid. So when you do go back and you see a big clot, it's because, in my opinion, because that tube got clotted off. So I think it's really critical that first 24 hours, but especially that first 6 to 8 hours when that patient's going from coagulopathic to being clotty. And did one of you guys want to address whether or not you think this changes the need for a pleural tube, yes or no?
Well, yeah, that was your first question. I think that I know that the VAD people, they use pleural flows in the pleural cavity as well as in the mediastinum. For now, from what we've seen, is you can put a standard chest tube if you've opened the left pleura, and that's going to do the job. I think that just because of the different location, just a chest tube in the anterior mediastinum wouldn't be enough if the pleura is open, obviously.
Yeah, and what we've talked about talking to folks around is, we wouldn't suggest whether you should put a pleural tube in or not. I think that's really up to the surgeon and the case. But when the study was done by Dr. Gillinov's team on the chest tube clogging, the mediastinal tubes clogged off a lot more than the pleural tubes. And I think because when the patient's laying on their back, most of that blood's coming from above that tube, from the bone, the fat, the periosteum, and that's where you want to get it all vacuumed up. So maybe a regular chest tube's fine on that left pleural space. So we haven't really sorted that out yet.
So just to elaborate on that point a little further, the Medicare data on coronary surgery in the United States shows that at 30 days, 50% of patients have pleural effusions, which contain red blood cells. And that's evidenced by interventions which are coded and billed for. So we know it's true. About 10% of those have volumes occupying more than a quarter of the left-sided space. So this is not an uncommon problem, and it's not a minor problem. Whether or not that blood can be avoided on the left side is really a question of where the blood comes from to begin with. Most of the time, and you can review the literature on this, the blood on the left side appears to be migratory from the incisional site and a function of inadequate drainage from the mediastinal area in the first place. So again, optimal drainage from an anterior mediastinal drain or a posterior mediastinal drain in the first 24 hours can have a tremendous benefit in avoiding the migration of blood to the left or the right side, depending on patient position, in the subsequent time after that.
Yes, sir.
What I've noticed among my partners in other surgeons, I no longer in the OR, critical care intensives, with cardiac surgery. The greater use, the increasing uses of the Blake trainers, and they put them on the suction bolts so they to the idea of getting them up, mobilized, and moving them around. What I'm also finding is the guy who's taking care of them post-op. I'm sending more and more patients down IR and that big pill to put in. I'm spending more time with respiratory problems, atelectasis, suction, all of those kind of things. The suggestion that I would make, and I apologize, this is a great product, it's a great presentation, a great concept. But I think you need to be able to come up with some data showing the superiority of using conventional testing with your device as opposed to the blades, because that's where the next battleground is going to be.
That's a great point, and we've talked a lot with folks about Blakes, and we've also done some studies that aren't published yet where we've taken Blake drains and then looked at them for clots. And when you look at the studies about Blake drains, they are non-inferior to conventional drains. they're not superior, okay? So they have the same problems regular drains do. People just like them because they're more flexible and smaller and that kind of thing. But I agree with you that that's something we have to address, and we've got some stuff going down that way.
I mean, they may not be inferior at this point, but you could compare it to the conventional tubes we have in the system.
Right.
So I think if you compare your technology to the plates, it's just my gut feeling that it's just would be far superior, even in terms of overall length today and the other parts.
That's a good point.
Well, we actually did a prospective randomized trial with Blake drain versus standard in high-risk procedures, so a lot of thoracic aortic stuff and combined procedures, about 100 patients in each group. And the endpoint, we were looking at the rate of pericardial effusion by echo in the first 30 days. First thing is we found no significant differences, so not helpful at all. It's published in GTCVS. And afterwards, we went back and we looked at the incidence of AFib in this patient population, and it was over 50% in both groups. So obviously no benefit, which is consistent with no superiority of the drainage.
And I think that's important because a lot of folks who like to use Blake drains, I mean, they have a reason for doing it. And I think they like the way they feel and they like the size, and they have this impression that it's better. But I think the data shows it's not better than a conventional drain. Now, we have to do the research to compare the Clearflow system to the Blake, I agree with you. But in Dr. Gillinov's lab a few years ago, there was a pig study where they took 32 French conventional chest tube on one side and 20 French Pluralflow on the other, and then exposed the pleura to a large volume of ongoing bleeding. And the 20 French Pluralflow silicone tube drained far superior than the 32 French conventional tube. It was the first time ever a small diameter tube was shown to drain better than a big diameter tube, published in the Annals of Thoracic Surgery, I believe. And that 20 French silicone tube is very similar to a Blake, so you're right. I think it would be interesting to put those head to head because there are, probably 10-15% of all surgeons use Blakes on a regular basis. Yes, ma'am.
Can you just comment on the upfront cost?
Yeah, I think those are really important questions. And like Dr. Gillinov mentioned, this really is a team thing. This isn't like sewing in a valve where it's really up to the surgeon and he or she's the only one who ever really gets exposed to a device. This is a device that's going to be exposed to every single nurse. So when the team goes in, Michael Cox and his team and Paul's team, I think recently they did this at the Mayo Clinic and a few places. They'll go in and train 250 nurses every single shift, nights and weekends, because this isn't something you want to surprise a night nurse who wasn't there for the in-service and stuff. So the company, I believe, really appreciates the fact that training is very important. They follow the number of complications very closely as they're required to do by the regulatory bodies. And then the percent of uses that have resulted in significant complaints is very, very small and closely monitored. You might worry about that loop going out a side hole, okay, but it's designed to prevent that. You might worry about it going out the end. It's designed to prevent that. One thing that's kind of a nuisance is if the tube gets kinked, like, you put it in kind of like this, and then maybe the patient gets positioned, it gets kinked, the loop won't go through the tube if it's kinked. And so sometimes usually you reposition and that gets better. So there are some technical features that you have to be aware of as the user. And that's part of the training. One surgeon, Billy Cohn, who's always good for some poignant conversation, said, if you're using the Pluralflow system and it stops working, like because it's got a kink or whatever, he goes, what are you left with? He goes, it's like when you're using an escalator and it stops working. What are you left with? Stairs. What are you left with? A chest tube. What have you been using your whole life? A chest tube. So if for some reason there was something like that, you just pull the thing back and you're back to a regular chest tube. But the more that the team trains, the more that they work with the nurses to get them comfortable with it, I think it goes really well.
If I could address the economics a little bit.
Yeah.
So,
Wait, just one second. He's going to talk about the.
Well, I must say that this is a question I've asked yesterday because the incidence is like 0.008% complication rate, but it's not related to the design of the tube. It was a chest tube that was actually sutured, and when they tried to pull it out, it broke.
That was my residence.
And I've seen it with standard chest tubes. So this has nothing to do with the mechanism. So the risk is very low.
Don't worry, that guy's in South America.
And aside from that, I think that first, the company has been very good training, and at the Montreal Heart, we only do heart. So I mean, the nurses, they have adopted it. They have their own tricks. They know that you should align, the outer portion should be aligned between the legs of the patient, so everything should be in continuity. I usually say it's a two-finger thing, not a, let's ram it in. It's like playing violin or something. I mean, and I think technically, and this is why we focus on the first study, doing the survey about with the nurses. Surgeons less important, they go, oh yeah, it's the same thing. But I mean, the nurses in the OR, in the ICU, they were very favorable to it. And even though, again, when you tell them do something every 15 minutes, I said, listen, do whatever you like as long as they don't clog, it's fine. But once we've shown in our retrospective data that this could have an impact on post-op AFib, the buy-in was 102%, because everybody got the importance of that problem.
So I'd mentioned earlier the Porter equation that is really driving CMS guidelines now for reimbursement with Medicare, the value equation that value equals outcomes divided by cost. So we actually spend a lot of time trying to calculate what is the value of this device and how should it be priced in the marketplace. And it costs $395 in the United States. If you look at the cost of complications related to retained blood, and we gave an indication of the average of about $28,000, there are centers that incur $40,000 or $50,000 per event cost, depending on the patient population, excluding post-op atrial fibrillation, which is about an $11,000 per event cost. The net economic benefit on a per-patient basis of using Clearflow is about $2,000 to the hospital, of which we obtain about 20% in our pricing. So it's an 80-20 split. The hospital gets the vast majority of the savings. We recoup about 20% of the benefit economically of using the device. And that's closely calculated from those hospital billing codes. These aren't numbers that we calculated ourselves using some fancy marketing work. We extracted AHRQ, National Inpatient Sample data, from hundreds of thousands of cardiovascular procedures by DRG. Then we looked at ICD-10 codes for reinterventions in the 30-day, 60-day, 90-day, and 365-day periods subsequently. And we looked at what the hospitals spent on those procedures and what was reimbursed. We calculated their charge-cost ratios, and we got to a net cost of these complications before we decided how to appropriately price our product. And this is the future for all medical technology. The upfront cost obviously can be a burden. The way our hospital systems operate, the chief of an operating room may see this as a $200,000 incremental cost. Getting a patient out of ICU a day earlier, having lower rates of infection, lower rates of post-op AFib, may accrue to an ICU budget differently. The CFO sees that at the top level. The departmental heads don't always see that. And we're in the middle of a revolution in hospital cost accounting and care management that is trying to get to grips with what is the true cost of care and how do you value new therapies. And really they have to be looked at the way we're looking at it. And I was very pleased to see Medtronic participating in this discussion yesterday with their cerebral oximetry data, which really operated along the same lines, that the days when the price of the bedpan drove the decision on whether or not to bring a device in or whether the physician liked the new feature or benefit drove the decision are over. And the new regulations for reimbursement will have a profound impact on hospital financing, and every new technology that is brought to a hospital must be justified in terms of clinical outcome benefit and economic benefit for the system. And we've spent a lot of time making sure that Pluralflow does that.
Right. Well, I mean, obviously, I don't stay in the ICU for hours and hours because I'm too sensitive for that. But the would drive me nuts. But And I'm asking you the question. My understanding is, depending on whether the patient is supine or not, they may feel it more. And if they're at 45 degree or sitting, they are almost sitting, they might feel it more. So it may be a question of that too. That's what I've been told.
And I do ask them, like, is it horrible pain? Because I do need to do this. And they're like, no, I can just feel it. And so, like I said, this one patient who was just great. He was great. And so I look at my and I literally go, what's going through? They really can feel it. He was asleep and it woke him up.
Well, chest drains are notoriously painful, as we know, and if you manipulate them, even without a guidance system, the chest drain tends to be irritating.
Well, and I think you also have to look at that compared to chest tube stripping or milking, where there's probably a little bit more movement on that suture with some of those older stripping techniques. It's interesting. We all learned to strip a chest tube, and now there's a consensus statements published saying you shouldn't do it. It still gets done all the time, I think. And so I think, and when you ask a patient, what's the thing you remember most about your heart surgery operation? And they say the chest tubes, because that is the most dramatic thing. And the person wakes up, that's what they see, maybe the ET tube and then the chest tube. So it doesn't surprise me that they're aware of it, for sure.
For the nurses in the audience, Myra Cook at Cleveland Clinic published a poster at AATS about 2 years ago, which looked at the amount of time that nurses spend maintaining chest drain patency in the ICU after cardiac surgery. It's a very interesting paper. She broke out labor and effort for the nursing community. And it turns out that conventional chest drains after cardiac surgery occupy about 2 hours of nurse time in the first 24 hours. Pluralflow, by contrast, is actuated. That means moving the magnetic shuttle up and down 4 times per hour for the first 8 hours. It takes about 5 to 10 seconds. So the total burden of Pluralflow actuations in a 24-hour period is about 10 minutes compared to 2 hours of manual chest drain management with a conventional chest drain. So this is actually a labor-saving device. And the nurses where we've implemented, and that's some large hospitals, New York Presbyterian, Cleveland Clinic, Mayo Clinic, some of the best centers in the country are using this device now. The nurses, and we take great care to incorporate them into the best practice introduction. They love this device after it's introduced, and we're looking forward, obviously, to bringing this to be a standard of care across the whole world one day.
Thank you. Thank you.
Yeah, thank you.
My question is more of a practical question. One of the things that I see with this product, we use the product at CMC, we like it. But the nurses, the one issue that they have is sometimes the wire keeps getting stuck up in the chest and they're really hard time getting it down because the magnet, I imagine the magnet lets go for safety reasons. Do you guys have any suggestions on how to make that?
No, I think that's a great point. When we were designing this, we thought about how to move the guide wire with the loop in and out, and would it be a direct connection? And at one point we had an epiphany that maybe that should be an indirect connection and based on this magnet. That helps maintain the sterility inside the tube. But if you got if something like, when the patient sits up or moves and all of a sudden there's a kink and the thing doesn't want to easily go through, it just pops off. It's a magnetic safety release. So that is a safety feature. And you probably know more about it than I do because you've actually done it for hours and hours and hours. But
to get it down when it gets
yeah, but the point is, like, if that's happening and it's just not going to move or whatever, you just leave it there. You still got your chest tube, But what I've heard is when you put the patient flat or get a different position, sometimes it does. But it is a feature of the device that we put in there because we didn't want to have a situation. Let's say you could directly hang on to that thing. We wanted to say, hey, listen, if it's going in and out easy, great. If for some reason the patient's positioning changed and the thing's not going in and out, it's okay. That was kind of the take that we had on it.
I think we see it mostly. Mostly on people who are dry. People are simply not bleeding, completely dry.
Oh, interesting.
So
Yeah.
people kind of focus on to it. We never see them all bleeding.
No, when they're bleeding, no.
That's interesting. So when they need it less. Yeah. Yeah.
And it's a design challenge. I mean, we used to say in the beginning, how many ways are there to clean the inside of your fish tank without getting your hands wet? It's actually fairly tricky to figure out how to maintain the sterile field, avoid egress and ingress of the clearance member, avoid tube kinking, don't have it tied in too tight, don't let the blood freeze, so you must maintain the actuation schedule adequately and so on. So we deal with real-world events, and of course, every now and again, the device can be overwhelmed by those. The reported complaint rate in the United States is 0.189% on our total usage pattern so far, so it's about half of the industry average for a Class 2 device of this nature, and it's well within the normal bounds. But of course, there are going to be issues. We do have videos posted on the website, also available on YouTube for nurses and doctors, both for troubleshooting on the device. But of course, it's like any other technology. Once in a while, we'll get caught out. Yeah, I think we're here till 2:15.
Yeah,
So.
I think we've used up our time, but we'll be around if anyone has any individual questions, and we really appreciate you all coming today. So.